Okay, so in continuation of our abdominal imaging, we will talk shortly about the small bowel obstruction causes and radiological appearance by Dr. Khoshi Hassan.
Hi, everybody. The presentation of today will be about the small bowel obstruction. It's a nice and brief presentation. First, we have to have an idea about the anatomy of the small bowel. So it's a convoluted tube. I think everybody knows. It's around 6 to 7 meters long. It's divided into three parts: the duodenum, jejunum, and ileum. The caliber. Normally it has to be less than 2.5 cm. So whenever you have 3 and above, it's certainly dilated and extended. The wall it's made of 4 layers: the mucosa, submucosa, muscularis, propria, and then the serosum. So about the imaging investigations, we have many modalities. The easiest one, the abdominal X-ray, the barium follow-through, ultrasound, CT, and MRI. On abdominal X-rays, you have to have some features like the diameter should be more than 3 cm in order to say that the loops are dilated, or you may see air fluid levels and the string of beads sign. In cases where the bowel loops are filled with fluid and the patient is supine, so the air will be trapped between the valvular conniventis, and it will appear like string of beads. Later on, we will discuss the features on the other modalities. Next, please. So we have here an X-ray. It shows multiple air fluid levels in the center of the abdomen. So I think everybody knows that the small bowel occupies the center of the abdomen and it's framed by the colon. So normally we can have air fluid levels in the colon, but whenever they are big, large, and multiple, so we can say it's dilated. When you have 2 air fluid levels more than 5 cm or 5 air fluid levels more than 2 cm, you can say this is obstructed small bowel or dilated. Here, this is a patient although it's written upright, I think the string of beads sign will be apparent on supine position. The air is trapped between the valvular conniventis. You can point there, yeah. This is the string of beads sign. It's a sign of small bowel obstruction. On CT, I think it's clear that the small bowel, its function is to digest food. So, and the feces is not produced in the small bowel. It will be made in the colon. But whenever there's obstruction, so stasis and absorption of the fluid will lead to hardening of the content, and here appears like feces. This is like feces sign. It's called small feces sign, apparent on CT scan. It's obvious here.
And you have the string of beads sign
String
here.
of beads, yeah.
And you have dilated fluid front with air fluid level.
Air fluid levels, yeah. Regarding causes, we can classify it into three parts: extrinsic, intrinsic, and luminal lesions. The extrinsic one, you have many, like adhesions is the most common. Second is the hernia. We have volvulus, masses, more rotation, and balance. The mural one, the pathology is in the wall of the small bowel. So we have inflammatory strictures like in Crohn's disease, TB, radiation nitrites, and ischemia and intussusception. The luminal lesions, the lumen is obstructed. It's a mechanical obstruction. So we may have a gallstone impact on the lumen, causes gallstone ileus. We may have foreign bodies like bizarre, or sometimes tablets may cause obstruction. Parasites, yeah. Whenever you suspect a case that there may be obstruction, you should ask yourself, is there obstruction? So if yes, or what's the level, at what level the obstruction is? Is it complete obstruction or is it partial? Because the management differs. And lastly, what's causing that obstruction in order to have the diagnosis? So on X-rays, we see that the loops are dilated. In order to distinguish between them, which this is a small bowel dilated or large bowel, we have some features to help. In case of small bowel obstruction, the number of the loops are, it's a convoluted tubule, so it's more numerous. While in large bowel, it's less. The position is central in case of small bowel, while the colon is periphery of the abdomen. The size in small bowel obstruction rarely exceeds 5 cm, but in colon it's usually more than 5. And also, in colon we have hostra, which are incomplete bands across the width of the bowel, but in small bowel we have valvular conjunctives. These are complete bands crossing the width of the bowel. So when it's seen, we can see stack of coins like in the X-ray. And the valvular conjunctives, they are most prominent in the jejunum and less in the terminal area, in the ileum, I mean. The content, we know that fluid and gas is the content of small bowel, while feces may be seen in the large bowel. So we're going to talk about some important causes of the small bowel obstruction. The most common is adhesions. It accounts for like 75 to 80% of cases. Mostly it is because of previous operations, most commonly. There's no any specific feature to diagnose it like on any modality. Some helping features like there will be tethering of the bowel in CT scan, and there's point of transition you can see, point of transition between dilated and normal or prolapsed bowel beyond the point of the transition. So here you see, here you see the point of the transition and the dilated loops of small bowel. The same here, and air fluid levels. Okay, hernias. My colleague talked about hernias, so it's logical that may cause obstruction. So whenever the blood supply is compromised, it's called strangulated hernia. In case of closed loop obstruction, you have a loop of bowel which is obstructed at 2 points. Two loops at one point it's obstructed, so it makes like an inverted U shape. So the blood supply will be compromised because it makes pressure on the point. About masses, we have like peritoneal masses and small bowel tumors, benign, malignant, metastasis, anything can cause. Here we see the lumen of the bowel dilated. There is
Rather dilated. This is narrowed.
Yeah, the narrowed part. It's a structure. You can see a mass causing obstruction. It's not a complete obstruction; it's partial obstructed, and shouldering the lumen. So this goes with the adenocarcinoma of sweet bowel. In Crohn's disease, it's a chronic granulomatous disease of the intestine or the GIT. Any part from mouth to anus can be involved. It's characterized by skip lesions where you may have normal bowel intervening the lesions. It's 95% of cases the terminal ileum is involved. So it's logical to ask yourself how Crohn's disease it causes obstruction. It can cause by three ways. In case of active disease, where there will be active inflammation, so anywhere inflammation causes edema and swelling, so there is a transmural process. The wall will be edematous and causes obstruction. Or in long-standing cases, you may have fibrosis and stricture, and the third cause may be due to previous surgeries, so it will lead to adhesions. Yes, please. Sorry, previous one. You can comment on the pictures. Here you see the small bowel is narrowed.
Cobblestone.
Yeah, cobblestoning. And here there are multiple pseudodiverticulars. And the lumen is narrow, pseudo, and the bars dilated. And these are small office ulcers seen in the wall. Next, please. Ischemia. Anywhere in the bowel, whenever you have compromised blood supply, it may be due to arterial or venous. The arterial one either due to embolism or thrombus, and also venous thrombosis. Here, there will be edema of the wall and hemorrhage, and also some printing sign may be seen on imaging modalities. Later on, when the bowel will be necrotic and it will die, so the air may go inside the veins. There may be air in the wall of the small bowel. This is called pneumatosis. It's a late sign. Or there may be blood in the gas, in the portal venous system or mesenteric blood vessels. Next subject, it will be intussusception. Usually the susception is ileocolic, where there's telescoping of the distal proximal part of bowel into a distal part. So it's logical that it will cause the obstruction of the lumen. You can see here. So it will cause, in ultrasound, it may appear like a kidney sign. You see, it's just like, appears just like the kidney. The outer hypoechoic region and central echogenic. This is the wall of the colon. Here it's
This is the ileum.
edematous. The ileum is inside. It's seen in, you may see it in transverse, when you see the transverse view of the abdomen in case of ultrasound. And this one is the CT scan. Oral contrast is given here. This is the wall of the colon extended, and the contrast is seen in the lumen of the mouth. The black one, the hypoechoic one, this is the fat. Hypodense, I mean. This is the mesenteric fat seen inside the lumen of the colon. It's the mesentery of the small bowel. That's it. Gallstone ileus. It's a rare condition where the stone inside the gallbladder, it will erode the wall of the inflamed gallbladder. It will go into the duodenum and it lodges in the terminal area because it's the narrowest part, so causing obstruction. It will lead to signs of obstruction is seen in half of cases in case of gallstone ileus. And 1/3 of cases you may see the stone itself here. You can see the stone in the region of the pelvis. Yeah. Whenever you have air in the biliary tree, dilated small bowel and obstruction, and the stone, this is called regular strapid. The gas within the biliary tree, it's central one, branching pattern. So anybody can tell me about most common causes of hair in the biliary tree? Yeah, the most common is sphincterotomy. Other interventional procedure. Fistula, yeah. So we covered the most common subjects, and we have now some photos to look. Anybody can comment on this one?
Abdominal X-ray is fine. Show dilated small bowel. Mesh
That's a mesh.
Maybe hernia.
I don't know.
There's some sort of
But here you can see the valvular conventi crossing the width, so it appears like stack of coins. From this photo, you cannot identify the cause because you don't have the history.
But it's a small bowel, pure small bowel.
Small bowel obstruction. Yeah. Here you have multiple air fluid levels, and it's in the center of the.
So this is erect or supine?
It's erect.
It's written here.
Yeah, it should be erect because you see a finger. It's the same in the center and filled with gas. Small bowel obstruction. In ultrasound, it's useful in some cases. What you see in ultrasound, you see like pro and forward and backward flow of the bowel content. You may see the thickened wall of the bowel. That's what you see here, the dilated bowel. And in CT scan, we may have, just as my colleague said, the Whirlpool sign, which is a sign of rotation of the mesentery around itself. Here it's obvious.
So what do we have here?
When you scroll it, you can see that there is dilated loops of the small bowel.
We have small bowel dilatation with multiple large air fluid level. Okay.
In the region of the pelvis.
And if we go to the pelvis, we will see what?
Here you see the loop of bowel.
This
extends into the hernias.
And inguinal hernia, which is obstructed as the cause of.
And in the sagittal, it's also obvious. Very nice.
Let's try. Okay. See here? Shown side. The neck.
The neck of the hernia causing obstruction of the loop of the small bowel.
Okay.
This is the abdominal X-ray. It shows dilated small bowel loops. The cause is not as obvious here, but in CT scan we can see there is inflammation in the ileocecal region. This is a case of Crohn's disease.
What do we have here?
Anybody can comment? Small bowel obstruction. Yes. Multiple fluid events. So this is a case of post-operative case. The case was operated for hysterectomy and total abdominal hysterectomy and bilateral salpingeal oophorectomy. So after 5 days, she presented with abdominal distension, pain, vomiting, and this was the X-ray.
Beautiful.